So welcome back students. So I hope you have been enjoying this exam rapid revision series, and now let us discuss the next series of cases. The case number 26, if you see, so you see a 40-year male with lytic lesion in the proximal tibial epiphysis. So what do you see over here? Sections from this tissue shows multiple, multinucleated giant cells. Okay, multiple multinucleated osteoclast like giant cells can be appreciated over here. Along with that, in between you can see these stromal cells. Okay, you can see the stromal cells with pale eosinophilic cytoplasm with rounded to oval nucleus. Okay, as we can appreciate over here, the nucleus is bland, and you can also see areas of mitotic activity, but no necrosis as such can be appreciated over here. Okay, so these are the osteoclastic multinucleated giant cells. Okay. So the section shows a tumor mass composed of large number of osteoclast like multinucleated giant cells, between which are scattered mononuclear round to oval and spindle cells with pale eosinophilic cytoplasm and nucleus with dispersed chromatin and small nucleoli. Scattered mitotic figures are present. There is no necrosis, as we have already highlighted. So it is a case of a giant cell tumor of the bone. So giant cell tumor is highly cellular lesion, typically dominated by large number of non-neoplastic osteoclasts like giant cell with 100 or more nuclei, between which uniform oval mononuclear tumor cells are embedded. These mononuclear cells are round to oval, usually uniformly scattered or distributed throughout the lesion. The mononuclear cells may be spindle shaped and may even have a storiform pattern. This may lead to a mistaken diagnosis of fibrous histiocytoma or non-ossifying fibroma if the spindling pattern is dominant. The neoplastic cells have an ill-defined cell membrane with pale eosinophilic cytoplasm. The nucleus exhibits an open chromatin and contain 1 to 2 small nucleoli. However, it is difficult to distinguish the neoplastic cells from macrophages, which are CD68 positive cells without immunohistochemistry. Necrosis and mitotic activity may be prominent, but atypical mitotic figures should not be seen in typical giant cell tumor, and cytological anaplasia is absent over here. Okay. So let us now come to the important question. So we have discussed the key important histological points. So enumerate the giant cell containing lesions. Okay, so very importantly, let us see the giant cell containing lesions. So you can have reactive lesions, benign group of lesions, and malignant group of lesions containing giant cells. So what are the reactive conditions containing giant cells? Brown tumor, giant cell reparative granuloma, pseudomalignant myositis ossificans, tubercular osteomyelitis. Under the benign entities, we are having giant cell tumor, aneurysmal bone cyst, chondromyxoid fibroma, chondroblastoma, non-ossifying fibroma, Langerhans cell histiocytosis, and benign fibrous histiocytoma of the bone. Among the malignant conditions include malignant giant cell tumor, clear cell chondrosarcoma, giant cell rich osteosarcoma, and metastatic carcinoma. Okay. Now coming to the next important question. Okay, classify the bone tumors with a special emphasis on osteoclastic giant cell rich tumors. Now if you see in the current WHO 5th edition, okay, the division is as such. So you are having osteogenic, chondrogenic, osteoclastic giant cell rich group of tumors, notochordal tumors, and there are other groups like vascular or other mesenchymal and fibrogenic tumors. Okay, among them, okay, we are mainly, if you enumerate the osteoclastic giant cell rich tumors, if you see, it includes these three entities mainly, that is giant cell tumor of the bone, aneurysmal bone cyst, and non-ossifying fibroma. Okay, so this is according to the WHO 5th edition. But if you want to remember the classification in short, okay, so you follow what is given in Robbins. Okay, so basically the tumor can be divided under 4 major heading. One is the bone producing tumor, cartilage producing tumor, tumor of unknown origin, and notochordal tumor. So under the bone producing tumor, we are having osteoid osteoma arising from metaphysis of long bone within the age group 10 to 20 years. Then you have osteoblastoma arising from the vertebral column, age group 10 to 20 years. Osteosarcoma, which is a malignant lesion arising from metaphysis of distal femur and proximal tibia, that is at the end of long bones. Okay, again arising in 10 to 20 years of age. So you can see bone producing tumor, they are presenting basically at a younger age group. Okay, so if you see a bony lesion, younger age group, think mainly in terms of bone producing tumor. Second is your cartilage producing tumor, the first entity becoming osteochondroma arising from metaphysis of long bones, age group 10 to 30 years. Chondroblastoma, epiphysis of long bones, 10 to 20 years. Chondromyxoid fibroma, tibia and pelvis, 20 to 30 years. Chondroma, small bones of hand and feet between 30 to 50 years, and the malignant entity over here is conventional chondrosarcoma arising from pelvis and shoulder 40 to 60 years of age. Next group of tumor is the tumor of unknown origin, which is comprising giant cell tumor arising from epiphysis of long bone, age group 20 to 40 years. Aneurysmal bone cyst, metaphysis of proximal tibia and distal femur, metaphysis of long bones and vertebra 10 to 20 years. Ewing sarcoma is a malignant tumor arising from diaphysis of long bones, age group 10 to 20 years. Adamantinoma, again malignant lesion arising from the tibia, age group 30 to 40 years. And the last group is the notochordal group of tumors. Okay, if you see, so it's a chordoma, which is a malignant tumor arising from clivus and sacrum in the age group 30 to 60 years of age. So this is how you can remember the classification as well as the most common site, okay, of these tumors and the age group. This is very, very important for you, okay, so as to, you know, understand the clinical history, and it is going to help you to make a diagnosis, okay, in a much easier manner. Okay, so this is the basic important classification. Next question is, name other tumors which are arising from epiphysis of long bone. So one is the GCT that we have seen. Next is chondroblastoma, and then we are having a variety of chondrosarcoma, that is clear cell variety of chondrosarcoma, when they are arising from the, you know, metaphysis, diaphysis, but they might reach the epiphysis end of long bones also. Okay, so in that case, okay, so in case of clear cell chondrosarcoma, they might reach the epiphysis also. What is the characteristic mutation present in GCT of the bone? Very importantly, 95% of the cases they are harboring this characteristic H3F3A gene mutation, out of which approximately 90% of which are H3.3P glycine 34 tryptophan, with the next most common being a P glycine 34 leucine, okay, variety. Now describe the classical HPV features of GCT of bone. We have already discussed, so not repeating again. What are the differential diagnosis of GCT? Very important. First important is your aneurysmal bone cyst. Okay, how do you differentiate? Aneurysmal bone cyst is arising from the metaphysis, and they show characteristic USP6 gene rearrangement. Number 2 is chondroblastoma. They arise from immature skeleton and they show chondroid differentiation. Number 3, giant cell rich osteosarcoma, which is basically composed of pleomorphic cells, okay, as compared to bland cells of giant cell tumor, and giant cell reparative granuloma like lesions, including so-called brown tumors of hyperparathyroidism, and 5th, benign fibrous histiocytoma of the bone. Okay, now discuss the prognosis of giant cell tumor. So let me just discuss the prognosis of giant cell tumor. So if you see, approximately 15% to 50% of conventional giant cell tumors will recur locally after curettage, and usually within 2 years. Okay, between 3 to 7% of the patients, okay, they can develop metastatic lung disease with histological features of conventional giant cell tumor. Vascular invasion is commonly seen in cases that metastasize to the lung. Now the medial interval between metastasis and local recurrence is 15 months, and most occurs within 36 months. Pulmonary metastases are slow growing and are thought to represent pulmonary implants that result from embolization of intravascular growths of giant cell tumor. Some may regress spontaneously. A small number exhibit progressive enlargement and lead to death of the patient as a result of reduced lung volume. Denosumab has been used with benefit in treatment of benign metastasizing disease. The prognosis for patients with secondary malignant giant cell tumor is similar to that of patients with high-grade sarcoma and is reported to be worse than that of patients with primary malignant giant cell tumor. So this is about your prognosis of your giant cell tumor. Okay. So what are the secondary changes that you can see in a giant cell tumor? So you can see a symplastic or pseudoneoplastic changes, which is nothing but pleomorphism. But this pleomorphism should not be mistaken as a features of malignancy. So these are degenerative changes. Second is you can see cystic changes. Okay, you can see reactive or metaplastic bone formation, or you can also see secondary ABC or aneurysmal bony cyst-like changes also, as well as fibrosis you can appreciate. So these are the secondary changes you can see in a giant cell tumor. Does IHC play a role in diagnosis of GCT? Yes, in difficult or challenging cases, it plays an important role. Most of the tumors by immunohistochemistry will show positivity for H3.3 G34W. So immunostains for this, okay, and P63 are positive in mononuclear neoplastic tumor cells. Now remember one thing I would like to highlight over here. Over here there are two group of cells. One is this osteoclastic giant cell. Another is this mononuclear stromal cell. So remember, this osteoclastic giant cells, they are non-neoplastic group of cells, whereas this mononuclear stromal cells, if you see, these are the real neoplastic cells. Okay, remember this point very importantly. The examiner will ask you this question. So what is the cause of proliferation of osteoclastic giant cells? So why in this tumor, among so many tumor cells, why is this osteoclastic giant cell proliferating? So the neoplastic stromal cells are the primitive osteoblast precursors which is expressing a high level of rank ligand. This rank ligand in turn promotes the proliferation of osteoclast precursors and therefore helps in their differentiation and proliferation into mature osteoclastic giant cell that we see. Okay, so this is the pathogenesis behind it. Now, very importantly, what is the effect of denosumab drug that we use in this condition? The expression of high levels of rank ligand on neoplastic mononuclear cells has led to targeted therapy, okay, with anti-rank L ligand antibodies, that is denosumab. So because all this, that you see that there is a high expression of rank ligand which is driving the tumor and leading to proliferation of osteoclastic giant cell. So they have developed antibodies against this rank ligand which is stimulating this osteoclastic growth. This denosumab is the anti-rank L antibody. Giant cell tumors treated with denosumab for several months will show substantial new bone formation associated with bland neoplastic mutant spindle cells and a striking depletion of osteoclast like giant cells. These features may mimic de novo osteosarcoma or secondary malignant giant cell tumor. However, denosumab treated giant cell tumors, they lack substantial nuclear atypia, or they do not have any high mitotic activity or any atypical mitotic figure or necrosis or infiltration of pre-existing bone. So this is how you differentiate a denosumab treated giant cell tumor versus a de novo osteosarcoma. Okay, this is a very important point of differentiation. Now discuss malignancy in a giant cell tumor. So if you see, malignancy in a giant cell tumor is rare, occurring in approximately 3% of all GCT of bone. Now this malignancy in giant cell tumor can be of two types. It can be a secondary malignancy in a GCT, or it can be a primary malignancy in a giant cell tumor. So secondary malignancy in a GCT is more common scenario. It is defined as a metachronous high-grade sarcoma superimposed on a previous biopsy verified benign giant cell tumor treated by either surgery or radiation. The subset of tumor treated with radiation can be considered either malignancy in GCT or a post-radiation sarcoma. So secondary one is basically secondary to something. Already a previous history of benign giant cell tumor is there. Primary malignant giant cell tumor is a rare tumor wherein synchronous high-grade sarcoma occurs within a benign giant cell tumor. So over here everything is happening together, whereas in a metachronous or in a secondary variety initially was benign giant cell tumor, later on it progressed and formed either secondary to treatment or secondary to something it developed. In either scenario, the high-grade sarcoma component is often an osteosarcoma, undifferentiated pleomorphic sarcoma or fibrosarcoma. Now, because the primary and secondary malignant giant cell tumor can be immunoreactive with the IHC for H3.3 G34W, therefore, this IHC marker is not helpful in determining if a tumor is benign or malignant. It can only confirm whether it is a giant cell tumor, but it cannot confirm whether it is a benign or it is a malignant giant cell tumor. The prognosis of patients with malignant giant cell tumor is generally very poor. So with this, we have discussed this case number 26. Now we are going to go to the second important case, that is the case number 27. Okay, what is this case? Let us see. It is a 16-year male with pain and swelling around the knee joint. CT MRI shows fluid levels. So it is a classical case of an aneurysmal bone cyst. So you can see that there are multiple cyst-like areas. Okay. And these cyst-like areas are separated by fibrous septa, which is containing certain spindle-shaped cells along with giant cells over here. As we can appreciate over here, some reactive bone formation is also there. Why we are saying reactive? Because you can see the lining osteoblastic cells over here. Okay, you can see the lining osteoblastic cells over here. So it is a case of an aneurysmal bone cyst. So microscopically, you can see the cyst of various sizes separated by a fibrous septa composed of loosely arranged myofibroblastic bland spindle cells admixed with multinucleated osteoclast-like giant cells. Mitotic activity is common, but cytological ATP and atypical mitosis are absent. Finally, calcified matrix is also commonly found within the fibrous septa. Reactive woven bone rimmed by osteoblast can be appreciated, that we have shown over here. So it is a case of a classical case of an aneurysmal bone cyst, because you see so many cystic changes. Okay, remember this point. So what is the most common site of aneurysmal bone cyst? The majority of the aneurysmal bone cyst is arising in the metaphysis of long bones and the vertebra. When the lesion involves the vertebra, it is involving the dorsal or the posterior elements only. So this is the first point of difference from GCT. GCT is arising in the epiphysis. Giant cell tumor is arising in the epiphysis. Whereas aneurysmal bone cells, they are arising where? They are arising in the metaphysis. Name the molecular alteration present in ABC. So remember, rearrangements of USP6 gene has been found in 70% of primary ABC, but such gene rearrangement are not seen in secondary aneurysmal bone cyst like changes. Which other tumor also show this USP6 gene rearrangement? It is seen in nodular fasciitis, myositis ossificans, fibro-osseous pseudotumor of digits, fibroma of the tendon sheath. I know that you people are realizing that both these slides, GCT and ABC, they are very commonly asked slide in the exam. Okay, and you are thinking, that we can very easily answer these questions. But whenever the questions are asked, the only answer you are giving, giant cell is present, giant cell is there, so the answer is this. Okay, you are not able to answer these very commonly asked questions in the exam. You tend to fumble in the exam. Okay, so these are very, very commonly asked questions. So you have to be very, very thorough with these answers. What is the classical histopathological feature of ABC? We have already discussed in detail. Name other tumors associated with ABC-like features. So as I told you, ABC-like feature, ABC can be primary having USP6 rearrangement, or it can occur as a secondary change. Okay, secondary to certain condition. For example, ABC-like feature can be secondary to giant cell tumors. It can occur secondarily in chondroblastoma. It can occur secondarily in osteoblastoma, osteosarcoma, or in fibrous dysplasia. So these are the conditions where there can be secondary ABC-like changes, but they are not ABC, because whatever ABC-like changes which are present secondary to these tumors or these lesions, they will not contain USP6 gene rearrangement. Remember this point very carefully. And remember, previously they used to use the term secondary ABC or ABC-like changes. Okay, but this term is no more recommended by WHO. WHO is using the term tumor associated with ABC-like features. Okay, it is not secondary ABC. Why? Because they do not contain the same molecular alteration which is present in the primary ABC tumor. Okay, so discuss the differential diagnosis of ABC. Number one is giant cell tumor of the bone. So already the histopathological difference and even the molecular alteration in both of them are different. Second is simple cyst. Third is telangiectatic osteosarcoma. Now over here also fluid levels can be there, but over here there will be very high pleomorphism is there, which is not present over here. You will not see any cytological atypical mitosis. Even the tumor cells, they are bland. They are not pleomorphic as seen in telangiectatic osteosarcoma. Again, other differential diagnosis, the tumor with secondary ABC-like areas, secondary ABC-like changes. Now remember, in any of these entities, fibrous dysplasia, GCT of bone, chondroblastoma, osteoblastoma, osteosarcoma, so if certain areas are showing ABC-like changes, but majority or at least in some areas, the classical features of the parent tumor, like classical features of GCT, classical features of chondroblastoma, classical features of osteoblastoma, classical features of osteosarcoma will be there. Secondarily, some ABC-like features are there. So that is how you can differentiate. Name other tumors involving the metaphysis. So it is osteoid osteoma, osteosarcoma, osteochondroma. Already the details we have discussed over here in the GCT slide. So we have already seen over here. I have shown you this particular very important, this chart has been shown. So please go through this chart. It is very, very important chart. Okay. Coming to the next case, case number 28. If you see, what do you see over here? 18-year female with painful subungual lesion measuring approximately 0.8 centimeter in diameter. Now the diagnosis is lying in the history. It is a well circumscribed tumor, as you can appreciate. Okay. Wherein there is a monotonous, wherein the tumor is highly cellular, comprising of monotonous population of tumor cells having pale eosinophilic cytoplasm, and they have punched out nucleus. The nuclear, with a punching machine, whenever you punch, okay, you see a very round nucleus, you see round paper bits coming out. So the nucleus seems like punched. It is a bland looking nucleus. Small nucleoli is also visible with an open chromatin, as we can appreciate. Right. So what is the classical diagnosis? It is classically a diagnosis of Glomus tumor. It is a well circumscribed tumor comprising monotonous bland looking tumor cells with pale cytoplasm, large centrally placed round to oval punched out uniform nucleus with sharply defined cell borders. So histologically, remember, most of the Glomus tumors are well circumscribed, composed of varying proportion of Glomus cells, blood vessels and smooth muscles in varying proportion. So these cells that you see, this is the Glomus cell, and Glomus cell is basically, it is derived from it is actually a derivation from the perivascular cells. From the pericytes they are obtained. Okay, so these are the origin of the glomus cells. Okay, so they are composed of varying proportions of glomus cells, blood vessels, and a smooth muscle. Okay, remember the glomus cell, they are basically arising from the perivascular smooth muscle cells, which are basically involved in thermoregulation. Okay, pericytes, they are arising from the perivascular cells or the pericytes. Okay, solid glomus tumors accounts for approximately 75% of the cases and are composed of nests of glomus cells surrounding capillary sized vessels. A typical solid glomus tumor is composed of numerous monotonous rounded glomus cells with pale eosinophilic cytoplasm and centrally placed round to oval punched out nucleus with sharply defined cell border. So 75% of the cases of glomus tumors, they are solid glomus tumor cells. The surrounding stroma is often edematous and shows extensive areas of myxoid degeneration. Small blood vessels are scattered between the tumor cells. Minimal mitotic activity is there. The second variety is known as glomangioma, also called as glomerulovenous malformation. They are most common in patients with multiple or familial lesions, accounts for approximately 20% of the cases, and are characterized by cavernous hemangioma-like vascular structures surrounded by small clusters of glomus cells. Okay, this is the second variety, glomangioma, and third is glomangiomyomas, which is representing 5% of the remaining cases. Such cases, they show transition from typical glomus cells to elongated cells resembling mature smooth muscle cells. That is glomangiomyomas. Okay. So classify vascular tumors. So I will tell you, if you see the classification of vascular tumors, just follow this classification, this very simple classification. So first is benign vascular neoplasms, including perivascular and acquired developmental conditions. So you have hemangioma. So we are having broadly capillary hemangioma, a subtype of which is lobular capillary hemangioma or pyogenic granuloma. Second is your cavernous hemangioma. Lymphangioma can be simple, capillary, and cavernous cystic hygroma. Pericytic or perivascular tumors include glomus tumor, myopericytoma including myofibroma, and angioleiomyoma. Reactive vascular proliferations include bacillary angiomatosis, and vascular ectasias include nevus flammeus, spider telangiectasia, hereditary hemorrhagic telangiectasia. Intermediate grade vascular neoplasm include Kaposi sarcoma and hemangioendothelioma, and malignant neoplasm include angiosarcoma. This is the simplest classification that you can remember. Okay. Next important question, what is the origin of glomus tumor? They arise from modified smooth muscle cells, which are perivascular cells of glomus bodies, arteriovenous structures. Okay, so they are arising from modified smooth muscle cells of glomus bodies, arteriovenous structures, which are involved in thermoregulation. So what are these modified smooth muscle cells? So these are nothing but glomus bodies or arteriovenous structures involved in thermoregulation. Typical HP features we have already discussed. Enumerate and differentiate between the different subtypes of benign glomus tumor. So what are those? Solid variety 75% we have already discussed. Glomangioma 20%, which is cavernous hemangioma like vasculature. Glomangiomyomas 5%, they are mature smooth muscle differentiation like. Glomangiomatosis, when there is a diffuse vascular malformation. Symplastic glomus tumors, they show marked nuclear atypia without any other feature of malignancy. Glomangiopericytoma, they are hemangiopericytoma like. Okay, they are hemangiopericytoma like. So these are the different subtypes of benign glomus tumor. Now what is the most common site of origin of glomus tumor? So most tumors are less than 1 centimeter in diameter, and they develop in the dermis or subcutaneous or subungual region of upper and lower distal extremities, especially the hands. They are most commonly found in distal portion of the digits. Okay, glomus tumors often occur in the skin or superficial soft tissues, although occasional cases occur in deep soft tissues or viscera. Okay, now discuss the IHC of glomus tumors. They typically, all types, they express smooth muscle actin and muscle specific actin, and they have abundant pericellular production of collagen type 4. Staining for H-caldasmon is also positive, whereas CD34 expression is focal or absent. Discuss the malignancy in glomus tumor and what is glomus tumor of uncertain malignant potential. So the diagnosis of malignant glomus tumor should be reserved for tumors showing either marked nuclear atypia with any level of mitotic activity or presence of atypical mitotic figures. Now a component of pre-existing benign appearing glomus tumor is often and most commonly present. Now there are two types of malignant glomus tumor, one resembling leiomyosarcoma or fibrosarcoma. So this is the one variant, and another malignant type is having primitive round cell tumor like feature. Now, IHC demonstration of smooth muscle actin and pericellular collagen 4 is required for this diagnosis in absence of any clear-cut benign precursor. So, if all these features are present properly, then it is all right. But if a benign appearing component is not present in the background, then you have to establish the origin of the tumor using smooth muscle actin and pericellular collagen 4. This IHC becomes important in that case. Now, glomus tumors which are not fulfilling the criteria for malignancy but have at least one atypical feature other than nuclear pleomorphism are designated as being of uncertain malignant potential. Although glomus tumors more than 2 cm in size and deep location were previously considered malignant, subsequent experience suggests that these have uncertain malignant potential. So you cannot regard them as malignant, glomus tumor. An infiltrative growth pattern, high cellularity, spindled morphology are also features significantly more common in malignant glomus tumors and glomus tumors of uncertain malignant potential. Okay. Now coming to the prognosis and prediction of glomus tumor. So typical glomus tumor or glomangioma or symplastic glomus tumors, they are benign. Malignant glomus tumors are aggressive with metastasis and death from disease in as many as 40% of the cases. Few large visceral glomus tumors without other atypical features, that is uncertain malignant potential, have behaved aggressively as well. Okay. Now coming to the behavior, we have already discussed right now. Next question, which molecular alteration is present in sporadic benign and malignant glomus tumor? Sporadic benign and malignant glomus tumors of soft tissue or visceral origin harbor recurrent notch gene family rearrangement with MIR143 notch 1 to 3 fusion genes in more than 50% of the cases. Any familial association? Yes. Multiple inherited glomangioma, also known as glomovenous malformation, it is an autosomal dominant disorder, has been linked to chromosome 1p alteration. The gene is named as glomulin or GLM1 gene. Uniparental disomy is also seen in 70% of such cases. Okay. Now the next important case is the case number 29. If you see there is a 37-year female with solitary rapidly growing mass, blue-red lesion around 0.5 centimeter on the lower lip. So you can see a well circumscribed tumor mass which is showing ulceration at one area. Okay, and this tumor mass is composed of multiple tumor lobules, and individual such tumor lobules they are separated by fibrous septa. And individual such tumor lobules, they are highly cellular, comprising of small blood vessels, as we can appreciate over here. Very importantly, among these blood vessels, you are having multiple mixed inflammatory cells. So you have neutrophils over here. Yes, then you have then you have lymphocytes over here. Plasma cells are there. So you have mixed inflammatory cells. So there is lots of inflammation with predominant neutrophilic infiltration can be appreciated. You can see another neutrophil over here. So you can see that there are features of capillary hemangioma along with inflammation and ulceration. So this is classically a case of pyogenic granuloma. So well circumscribed exophytic tumor mass showing lobular architecture with overlying areas of superficial ulceration. The tumor lobules are cellular, composed of numerous small capillaries with extensive areas of mixed inflammatory infiltrate. Background stroma is loose and edematous. Now coming to the important question, name the different types of hemangiomas.